I'm at the National Center for Tumor Diseases in Dresden, but my background is not medicine. I'm a computer scientist by training, but I work on the interface between medicine, computer science, and engineering since 15 years. Just to give you a short introduction, so here you can see the National Center for Tumor Diseases is directly located at the University Clinic campus, and it combines patient therapy and research under one roof. And we have an amazing infrastructure with different imaging modalities, and also an experimental operating room where we work closely together with the surgeons. So you can see it here, all different kinds of devices and so on. And part of our work is also visualization, but I have to admit, I'm not a visualization expert. We are using it because it's a crucial and necessary component to visualize different information during surgery, but there are a lot of challenges which needs to be solved, and I will try to highlight some of them. As I said, we are an interdisciplinary group, and we work mostly on robot-assisted surgery, combining artificial intelligence methods with robots to improve patient therapy and to provide different assistance function. And just to give you an impression, maybe most of you don't know that postoperative complications are amongst the leading causes of death worldwide. And one reason is that about 50% of these complications are because of surgical errors. And there are also a lot of studies that show that the more experienced a center is, for example, in complex cancer surgeries, as you can see here, esophagectomy or pancreatic resections, the mortality decreases. I mean, this is something that makes sense, right? If you have a complicated surgery, you would also go to a center that it has a lot of expertise, but there are also studies that show that this is really the case. And so our goal now is how can we quantify this experience and make it accessible to machines. And if you're looking now in OR, you can see lots of different kinds of devices like navigation systems or robotic systems, different sensors like novel imaging sensors, ultrasound, and so on. Then you have a lot of different patient data along the surgical treatment path. So for example, you have preoperative imaging data, you have laboratory data, and so on. And then you have knowledge, and this can be divided more or less into factual knowledge, what you can find in books and so on. And then experience, and this is what I was talking about. And this is something we try to capture and to quantify it and to make it accessible. And this right now, there is a gap between these different kinds of fields, and we try to work on artificial intelligence methods to combine these different fields and to improve patient therapy. And this led to the Surgical Data Science Initiative, which was founded in 2016. It's an international endeavor with lots of different kinds of research partners, but also industries, and to combine these different stakeholders. And one key element is how can we translate the methods we are developing into the clinic, and how can we also evaluate it, what we are doing. And there are lots of different clinical applications we can think about if it comes to surgical data science. So you have like, we have the surgical treatment path, which consists of pre, intra, and post-operative phases. And In the preoperative phase, there are different assistance functions, for example, related to surgical planning. So you have like imaging data from the patient, you have MR or CT data, you can reconstruct 3D models out of it and use it for planning. You have intraoperative data, for example, based on the devices you use, a robot or novel imaging sensors, and you can use them for surgical guidance to enable an objective decision making. And you have postoperative data, where you can also use it to, for example, if you have data from the intraoperative course to predict complications and so on. And so just to give you an impression that these are different kinds of assistance function along the surgical treatment path, and visualization is a crucial component in all of these assistance function, because in the end, what we are computing and calculating with our methods needs to present it in a meaningful way so that it helps the surgeon and can improve patient outcome. And I picked today 4 areas I want to highlight a bit, and also make the link to the visualization component. And the first one is data. I already told you I work a lot in machine learning, and one major challenge right now is to have large-scale data sources, and mostly these data sources need to be annotated. So we are doing a lot of data recording in an intraoperative setting here in Dresden, but also in other hospitals. And we also have an experimental OR where we constantly record data. So this is, for example, imaging data from the laparoscope, the video stream we are recording, but also data from the robot and so on. And this has to be also combined with preoperative data. So when you have the data, you need to annotate it somehow. So an expert has to sit there and show, okay, here are the risk structures that should not be injured. Here's the target structure, or this is a complication or not. So as you can imagine, this takes a lot of resources, and you need experts for it, and experts don't have time. We are releasing now a data set for robot-assisted rectal resection, and this took us about 2 years to annotate this data. We also need to know what is the best assistance function depending on the phase of the surgery. So you have here this annotated data, and in the end, the machine learning method uses it to train, and then for a new surgery, it has to be visualized somehow. And as you can imagine, this does not scale because we need this data. We need to know what kind of assistance function is necessary to provide the right information at the right time. So we are also working on other strategies to generate data. And one strategy, for example, is to generate synthetic data. So as you can see here on the left, this is a basic simulation where we used a Blender to generate such scenes, but this does not look realistic and cannot be used for training. I mean, a big advantage if you use a simulation is that you exactly know the annotations, right? I mean, you know that these are instruments, and this is the liver, and this is fatty tissue, and so on. And now the challenge is, how can we generate realistic synthetic data? And there are recent advances in unpaired image-to-image translation that makes this possible. I won't go into the details of the methods because I wanted to focus on the visualization part. And you can also do this for videos, not only for single images. And the challenge here is that it is view consistent. As you can see here, we have a basic simulation, and this is the rendering or the texturing of the scene. And it's completely synthetic, but we can use it to train our algorithms with. So this is one way to overcome the data annotation challenge. I mean, there are also other ways like crowdsourcing to annotate the data, or methods such as self-supervised learning and so on. But we are working a lot on generating synthetic data. So the next step would be also to have longer videos and to include also tissue instrument interaction, and to have also complications. This would be the vision, but we are not there yet. So data encode is available in case you are interested. Okay, so one important thing is, if we have preoperative data, and this can be all different kinds of data, mostly imaging data, we can use it to assist in planning and also in decision making. So normally you have CT images of the patient, as you can see here on the left, and you can do a segmentation. For example, if you are interested in liver surgery, you would segment the liver and also the internal structures and the tumor and so on, and then you would get out a 3D model of it, as you can see here. And in yellow you can see the tumor. And if you are now going into surgery, the surgeon has a kind of mental model and has to merge it with the intraoperative scene. So we thought about, okay, can we assist the planning step beforehand? And we came up with an virtual reality framework to assist surgical planning. I can show you here the video. It's an older version. Right now we have a newer hardware, and we used also the controllers and so on to navigate with it. But in principle, it's the same. You can load patient data, different kinds of patient data, and you can look at the 3D model and also the radiological images. So the question was, can we improve spatial understanding with it? Because that's the challenge. Not only to present the data in a meaningful way for planning, but also to improve spatial understanding if you have like this immersive scene, especially for complex cases, as you can see here. This is a patient with metastasis in the liver. You can see here in yellow, and it's a kind of tricky case because you have to plan the operation so that enough liver tissue is left so that the patient survives, but you also have to ensure that the tumor is taken out, or tumor tissue. And the surgeons, they were quite happy with it, but we also did a small study where we compared a normal desktop view with a VR view, and we had like a scene understanding task for the participants, and afterwards they had a direction estimation task where they used a pointer and a printed 3D model. And the findings were that there was no advantage in spatial understanding compared to the desktop version. So these were first findings, and we have to see if it really makes an advantage to use it for surgical planning. Sorry. Okay, another example I wanted to show you, it's from our cooperation partners in Heidelberg, and they did a concept for human AI interaction in surgical oncology for liver surgery. So it's just a mock-up, but it was done together with designers, and they did an extensive user research, and you can see here in the video how it works in general. So you can load the patient data and use it for annotation. So everything should be presented in a meaningful way, because in clinical routine, surgeons, they don't have much time, and it can be used for decision support. So you can look at different strategies if you want to do a resection or a hepatectomy and so on. And you have also the patient at a glance. So you can see here the images and and also other preoperative patient data. It can be also used as a virtual tumor board, and you can also use patients or patients with similar pathologies and so on can be shown. But it's only a mock-up, so the basic methods behind it, they need to be implemented. But this was done by the designers, how something could look like. Okay, the next field I wanted to talk about is guidance. And as I said, we have like this CT data and we generate a 3D model out of it. And then we have the intraoperative view, as you can see here. If you do minimally invasive surgery, you have the laparoscopic video the surgeon uses to operate. And normally, the surgeon has like this mental model constructed out of the CT images and needs to merge it with this intraoperative view. So you can imagine, if you have a lot of experience, this shouldn't be a problem. But most of us, they don't have the advantage to get operated by the most experienced surgeon. So we thought about, okay, how can we enhance this kind of surgery by using navigation and using augmented reality visualization, so that you can visualize the virtual objects you get out of the planning with the operative scene. It's kind of like a navigation system in the car. You have your map, and then you have this intraoperative scene. And I won't go into the methods that are behind it. We use data-driven models to detect the structures and predict the deformation. I will mostly go now into the visualization part. And so you can see here how it is meant. So it's a Da Vinci surgery, a colorectal surgery, for example. We annotated a lot of data. So this is a phantom, but we used real patient data. Sorry, you have to drink a bit. So the surgeons annotated the data. We used it for the machine learning, and then we visualize it during surgery. And I want to highlight a bit the visualization part here now. So first of all, I have to pause it. I think it's really important that we have a kind of context-aware visualization, because a surgeon does not want to have a visualization all the time. Right? So the system should know which information to provide at which phase of the surgery. So we use the video stream to detect the phase of the surgery, as you can see here on the right, and also the task, what is done. And depending on that detection, an assistance function is started. So for example, to visualize the incision line, or to visualize the dissection plan, as you can see here on the right, or the detection of risk and target structures. I let it play. So this is the interface we provide, or we came up with. And behind machine learning methods that can detect the phase and assist and provide the assistance function depending on the phase. So this is called context awareness. But then we thought, okay, if you look at the visualization, it's okay, but it's really difficult if you have augmented reality, to deal with the depth perception, the transparency, and so on. So we teamed up with the chair of industrial engineering at TUD, and they thought about, okay, how can a visualization look like? And first of all, we cannot visualize it in the Da Vinci system because it's a closed system. So we have to provide a second interface, for example, a tablet, and also a touch display so that a surgeon can interact with the visualization. And then they also came up with different kinds of visualization. So as I said, if you use augmented reality, it's also difficult to provide a meaningful depth perception. So imagine that the virtual object and the real scene, or what you want to show, is at the same level of depth. So this can lead, for example, to distortion. And also to implement the transparency is not easy. And you have to adjust different visual parameters. You also have to think about maybe other visual cues to enhance the visualization, for example, also working with motion or inverse realism and so on. And then, as I said before, you also have to make sure that it's not cluttered all the time. So I think either context awareness or activation on demand could be also one means to realize that, because it should not be distracting. It should improve patient outcome in the end and should be meaningful for the surgeon. And then you also have to think about, okay, the hardware you use, the technology. I mean, here we can directly use the laparoscopic stream to visualize risk and target structures, for example. But if you have an open surgery, you need to have kind of AR glass, and I think these are not mature. The level of maturity right now regarding AR glasses is not at the level you want to wear it all the time. And this is another example where we provided an augmented reality visualization. It was the first in human trial and during the OR. So this is a 3D visualization. And the task here was to use the stereo endoscope we have and to measure the bowel length, which is important for this kind of surgery. So, and then we visualized the measurement and how much the system already measured. Because normally, again, the surgeon has to do it by himself or herself, and normally the estimation from the surgeon and what we measure differs a bit. So yeah, this was also a kind of virtual augmented reality we provided during surgery to improve decision making. Okay, and the last part I want to highlight is human-machine collaboration, and we are not working only on intraoperative guidance, but also on in training. Because normally to become an expert, for example, in laparoscopic surgery, which is quite challenging because you have these long instruments, you have only the 2D view, which is provided by the camera, difficult hand-eye coordination, and so on. So they have like these box trainers where they are working with, and so we also have here methods to do skill assessment. So if a novice is doing it, for example, I can show you here. This is a typical box trainer. We use computer vision to analyze the movements and the tasks that are performed, as you can see here, and to rate the medical students or surgeons or novices that are performing this task in reference to an expert model. We also recorded experts and made an expert model out of it. And these are standardized metrics that are used for assessment. And the next step is now, how can we provide targeted feedback to improve the learning curve? And one means but we have not implemented yet, is to have a meaningful visualization. So for example, to show the trajectory that an expert would take, or the angle in which the needle has to be grabbed, and so on, in reference to the expert. So visualization is one means, and here we implemented a haptic targeted feedback, so that as soon as the instrument moves out of the scene, which happens a lot in novices, you get a haptic feedback, and also the direction is shown in where to point the instrument. And another example is robot-assisted surgery. Also in the experimental OR, we mounted a laparoscope on a robot arm and learned the best view, what the surgeon wants to see, and it's automated, so the view is automatically adapted. And depending on the phase, we also visualize risk and target structures, as you can see here. So for example, here you have the virtual model, and then it's visualized, the tumor position is visualized in risk and target structures. You can also visualize the underlying CT images. So as you can see here, it can be also used for training purposes, for example. Okay, so these were some examples where we use visualization, mostly augmented reality, to provide an assistance. But there are a lot of challenges, and not only regarding the basic methods, and I try to link now the challenges with regards to visualization, because in the end, we want to translate the methods we are developing into clinical practice. I mean, there are also a lot of challenges regarding the methods part, but if you are looking now to, especially to visualization, there is the data challenge. So is the data available we want to visualize? And does it need to be pre-processed? Because a lot of times, as I have shown in the navigation system, the data needs to be pre-processed. So someone has to segment it and to reconstruct a 3D model out of it. And maybe that is not the only data we want to visualize, and so on. So there is a lot, and also regarding patient security and privacy. I mean, this is also a big topic. Then methods. So I won't go into the details of the AI methods, but more regarding the visualization methods. And this, as I said, there are a lot of challenges regarding augmented reality visualization in surgery. So as I said, depth perception is a problem, to render transparency or the adjustment of visual parameters, what kind of other visual cues can be used, or what kind of techniques regarding inverse realism, and so on. And then you have to integrate it somehow into the surgical workflow. And this is a basic component regarding translation. And there we have like the technology versus the software, the hardware versus the software, because the display technologies we have right now, when it comes to augmented reality, for example, the HoloLens and so on, as I said, it has not the level of maturity we need for surgery. And then you also have to provide intuitive human-machine interaction. So, for example, an activation on demand would be nice, or context-aware system. And in the end, you also have to show that what you are visualizing, or what you are developing, is helpful for the surgeon and improves outcomes. So you need clinical studies. And you also have to think about, okay, the augmented reality visualization, is it likely to help regarding accuracy, or is it improving speed, or is it reducing error, or is it helpful in objective decision making, and so on? And yeah, these are all challenges we need to solve. So I want to conclude with the vision of the OR of the future, which is a sensor-connected environment where we want to provide different assistance functions, for example, a context-aware visualization or prediction of the remaining time or complications or robotic camera guidance. And the important thing is that we need to provide the right assistance at the right time, and visualization, as I said, is a crucial part of it. Okay, so in the end, I want to thank the PhDs and postdocs who are actually doing the work I presented here, and also my collaboration partners, and yeah, especially the Cluster of Excellence, CT, and EKFZ, and the new AI school, CKI. So thanks a lot for your attention.